Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features Dr. Stephen Horwitz from Memorial Sloan Kettering Cancer Center in New York, Dr. Pamela Allen from Emory University in Atlanta, and Dr. Kerry Savage from the BC Cancer in Vancouver, British Columbia. They will be answering questions on T-cell lymphomas posed during a live symposium that was held at the annual Hematology meeting in December 2022. This episode is part of a larger educational program titled Advances in the Treatment of T-cell Lymphomas, a forum for data and case discussion. For more information on the experts, along with a link to the complete program including downloadable slide sets, an expert commentary, and an on-demand webcast covering the topics discussed in this podcast, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
So now we'll do Q&A. Okay, so one of the questions I think that comes up a lot, and I'd like both of your takes on it, is, the question is it indicated to use BV in patients with PTCL and CD30 negative? So Pam, you talked a little bit about the CD30 data in cutaneous T-cell lymphoma, but how do you sort of look at that in a patient with, why don't we say CD30 negative or CD30 very low, less than 1%, when you would or would not use that in approaching a patient? Maybe we'll talk about relapse setting, but then as well as possible upfront therapy.
How do we distinguish how much CD30 is enough CD30? So I'm going to talk about two studies that have looked at this. So there was a phase 2 clinical trial that looked at patients with variable expression of CD30 from 0 to 100%. And they found in the overall cohort that if you used more sensitive techniques, more than 90% of samples had at least some CD30. So we can't always necessarily trust totally our clinical labs. But the median expression was about 13% for mycosis fungoides. So a lot of patients will express some, but it might not be that high. When they looked at response rate by CD30 level, there actually wasn't a huge difference in terms of different cutoffs for CD30. But the difference was if patients didn't have a single biopsy that expressed at least 5%, then the response rate was much less. It was 17%, versus if you have at least one biopsy that has at least 5%, then the overall response rate is 83%. And compare this to another study that had a different way of looking at CD30, where basically they looked at the minimum amount of CD30. So if you had multiple biopsies, every single one of them had greater than 10%, that was positive. And if you had a patient that had even one biopsy that was less than 10%, that was negative. Not surprisingly, you can see that compared to physician's choice of methotrexate or bexarotene, regardless of the CD30 definition, both of those did very well in their overlapping lines. And to me, the take home of this means that if you have at least one biopsy that has some CD30 expression, that you should probably consider brentuximab at some point in time.
For CTCL, I still think that we really don't have a lot of good traditional options. So a lot of it depends on the stage of the patient. So for a tumor stage patient that doesn't have, you can't do radiation, or they've got just a little bit more extensive disease, or they've already had total skin, even if their CD30 level is low, I will consider it for that. And similarly, for patients with plaque stage disease, if they've already kind of run through a lot of the traditional skin-directed therapies, I think that that's a good time to be thinking about brentuximab if you're going to be thinking about systemic therapy.
And what if
broadly.
they're negative? Like, what if the pathologist says, I see no CD30?
Yeah, so if they see no I still think that you can do it. So one of the things I've been doing is sending some of those patients off for sequencing, and you can check CD30 by RNA, and then if it's expressed, I feel a little bit better about it. But even in a patient that's dead negative for CD30, I think with some of the data showing that I don't know how much I trust that it's truly negative. You can do a couple of other biopsies, or if they don't have any other great option, it's either brentuximab or chemo. You can consider starting brentuximab, and then if it's not working, you can kind of abandon it quickly.
And Kerry, maybe in Canada where there are actual rules, what you do or what can you do?
How would you approach that? Yeah, I mean, of course, being from Canada, we have more strict funding, so I wouldn't be able to access brentuximab vedotin in somebody CD30 negative. I think for the low expressors. You were the senior or the lead author on the non-ALCL paper. And the bottom line is by IHC, it doesn't correlate well with response. There were patients that progressed, I think, that had CD30 of 80% and others that with less than 10% that had CR. So it's a bit frustrating. And as you pointed out, there's more sensitive means. So I think for me, it depends on what I'm going to do. If there's any CD30 expression, and let's say I'm trying to get the patient to transplant, one thing is you do know if it's going to work. Usually the median time to response is about 8 weeks. So you might get lucky on it. And I will also point out that the mechanism of action of brentuximab is a bit more complicated than just being a microtubule inhibitor. It does have some impact on the microenvironment. So that may also be why you see some activity, even if they're negative. So for me, in a relapse refractory PTCL, just sort of summing up, if they're completely negative, probably not. But if they're low, and I would still consider it, because some of those patients do respond, and you will know early. What about you?
I start with that. I think we definitely see response in CD30 low. I think given our other options, I tend not to use it or very much deprioritize it in CD30 negative. And I think even in our study where there were some responses in CD30 negative, they weren't sort of like dead negative. Like eligibility required some CD30 and then some on re-review were negative. So I'm not sure that's a negative. So with the lack of other options, I think it's an active drug, but I tend not to use it in true negative. I think CTCL is a little different, where we know if we do multiple biopsies, there may be some heterogeneity, and but I would like to see some target. I still think of it as mostly a targeted therapy. There's a question: is there a role any for ruxolitinib, or maybe we just talk about JAK inhibition? And the question is MF or Sézary, but maybe Pam, you want to do CTCL and then toss it to Kerry for systemic T-cell lymphoma.
Yes, there's clinical trials looking at this, and there is some response. I have used it off-label, but that's been in a setting where I've kind of run through all of my options, and then we sequenced the patient, and we saw some, mutations, and thought, well, maybe we'll give it a last try. But other than that, I wouldn't tend to use it off-label. I'd use it only in a clinical trial.
Public payer country. I'd be looking for a clinical trial. As you know, there are some PTCLs that have activation of the JAK-STAT pathway. Alison Moskowitz did a nice study looking at ruxolitinib in different cohorts, depending on whether they had evidence of JAK-STAT mutation or not, or phosphostat. Off study, if I had a bag of drugs that I could get into, I would consider it in somebody that I didn't have other options. And particularly if there's evidence of activation of the JAK-STAT pathway, if you had mutational analysis, or if you could ask your pathologist to see if, is there phosphostat, but there's the US and then there's outside the US in terms of what we can access.
There's one other caveat that actually in gamma delta cutaneous T-cell lymphoma, there is known expression. So if you're able to get it in that disease, then it's reasonable.
No, and I think in the ruxolitinib study that Alison Moskowitz published is interesting. So the patients with pathway activation mutations did better, but there were almost no responses in CTCL in that study. There was only one really long-term responder. Where this other study we did with sertolatinib, which is a JAK1/3 TYK2, and Rux is JAK1/2, we did see about a 30+% response rate in CTCL, and I've always thought that's kind of interesting, why those data sets seem so different. It might just be small numbers, but really what looks like differential responses with drugs that we thought had fairly similar mechanisms. Question that I thought might lead to a larger question: any impression valemetostat may sensitize lymphoma to chemotherapy or immunotherapy? Does anyone have a take on that?
Oh, it's a good question. I don't have any mechanistic rationale that it would sensitize to chemotherapy, but immunotherapy coupled with a number of drugs, they are synergistic. So that is a possibility, but I'm not aware of any data, PD-1 inhibitors and EZH2.
And I've had a couple patients treated with valemetostat and that relapsed and then went on to systemic therapy and didn't do well, but if they were in CR and then you treated them, I don't know. So I don't have any personal experience to suggest, so.
I don't have data. I don't know anyone in the audience have data on direct sensitization. There's tazemetostat with chemotherapy data that's published. But that led me to think of a philosophical question, which I think you touched on, Kerry, in your session, is that we have drugs, at least I think of, maybe if you do too, epigenetic drugs that are quite active in these diseases, but we don't think of them as typically curative. And then we have chemotherapy, which we think of as moderately active but potentially curative. And this question, when you have a new active drug, let's take valemetostat as an example, are the next step after demonstrating single agent activity to combine with chemo in a curative setting, or maybe mechanistically combine drugs, and are those curative approaches? And I don't know, is that really a question or a statement? Like how do you sort of think about next approaches? Because in rare diseases, we can't always do 7 different strategies.
Yeah, I don't think there is a right answer. I am impressed with some of those combination novel therapy studies, but the bottom line is we still don't have long-term data to know how that translates into cure. I think probably some of them are, because we know from Romi, a single agent, that some of these patients are out 3 years, and I think they probably are likely cured even with BV. And I have to say, particularly with the TFH PTCL, I have maybe a little less certainty about CHOP than I do with PTCL on OS. So I honestly think I think they both potentially have merit. Both have pros and cons. There's toxicity in both. I'm not sure we can say which way to go one way or another right now. What's your philosophy?
I mean, it would be lovely if we could eventually do one of those like molecular-driven basket trials where we have mutations or pathways, and then that would be one of the things. But as was done in diffuse large B-cell lymphoma. But other than that, I certainly would be interested in a frontline combination that included it. But I don't know about by itself or with other just novel agents. I
mean, my personal feeling, I have a lot of anxiety about stepping too quickly away from curative therapy and upfront treatment, because as we take care of these patients, I think we could all agree that being cured is way, way better than not being cured, almost regardless of what it took to get there. And I worry, like when I look at the control arm of Echelon 2, the median overall survival is not met at 5 years. Now that is enriched for ALCL, but in the CHOP arm. So I just, I started with that, and I would favor a stepwise approach, but bold step forward if they're successful is certainly.
And I think I flashed up that slide about angioimmunoblastic T-cell lymphoma from the International T-cell Lymphoma Project, and those low-risk patients, virtually all treated with CHOP-like chemotherapy, it settles out at around 40%. So I think it also has to be individualized if you have a fit patient who can manage it. And our own poster showed that it didn't seem to impact if you alter the doses to customize it for an older patient either. Like we didn't find that was detrimental. So I think it's still, as of today, it still has to be our go-to as our quote unquote standard curative. But in somebody who's not felt to be a candidate, then I don't think it's unreasonable to explore novel therapies in the treatment naive.
There's a couple questions about CTCL patients with large cell transformation that talk about therapy and then the role of allotransplant. When you, I don't know, Pam, if you want to take this, when you would, or maybe I would say when you would think about consolidating a remission with large cell transformation of
in a young patient that's, I think, relapsed after more than 3 systemic lines of therapy, I think that's when I'm definitely looking at allotransplant. Large cell transformation by itself is not an indication for transplant, because some of them respond really well to radiation and never come back. Some of them are more indolent than others. But I think the age of the patient, the stage of the patient, and how quickly they're relapsing through therapy makes a difference for me.
Maybe either of you or both of you could address this. It was a little bit touched on the talks, and it's really a question just says thoughts about CAR T and their possible toxicity on normal T cells, sort of what's known.
Like fratricide? Is that what they mean?
Well, it says on normal T cells, so I guess T cell aplasia or fratricide, or do you have any expanded thoughts on, you talked a little bit about this in your talk, Pam, any expanded thoughts on CAR T cell and T cell lymphoma and possible, I guess, toxicity of that?
Certainly when you're treating a T cell with a T cell, it gets complicated. And so there is the whole idea of fratricide, which is the CAR T usually killing itself. But in terms of killing healthy T cells, I don't know that we have long-term data that's shown that there's been complete T cell depletion. I think that would be an event that would not be survivable in the long term. So patients do retain some T cells, but certainly a concern. I don't actually have a whole lot of personal experience with treating T-cell lymphomas with CTCL because we haven't, or for peripheral or cutaneous, because we haven't had those studies open. But certainly, like so there's a CD5, there's a CD30, and then the CD70, which is the allogeneic. CD5 CAR T has like built-in mechanisms to kind of go away. The CD30 is not uniformly expressed on all T cells, so it shouldn't completely deplete your T cell population.
There's some more questions about CD30. Do you treat PTCL that are CD30 positive in the EBV positive cells, but negative in the tumor cells? So I assume this means like AITL, where sometimes the immunoblasts, which are probably not the tumor cells, are 30 positive, but not the tumor cells.
I would actually. In the clinical trials, if you couldn't specify based on the tumor cell, they did allow CD30 expression of the whole microenvironment. I don't think we have data specifically of the efficacy in that situation, but I wouldn't completely not use it just because it's just the B cells that are positive, again, for the microenvironment effect potentially.
Yeah, and I think those are some of the responders of CD30 very low or negative
Maybe.
in AITL. Mm-hmm. Those are some of those. Mm-hmm. Those are all the questions that we have. Okay. Thank you. Thank you.
Thank you very much, Dr. Horwitz, Dr. Allen, and Dr. Savage. And thanks to you, the listeners, for joining us. As a reminder, to view the full program, Advances in the Treatment of T-Cell Lymphomas, a forum for data and case discussion, please click on the link in the show notes. As always, thanks for listening.